In this session, we're going to focus on the wound nurse role and the ostomy nurse role in management of fistulas. You may have noticed that fistula management is included in both the wound module and the ostomy module. And that's because no matter what you call yourself, they will call you. Fistulas are a huge challenge for all of us. We either feel wonderful because we came up with a management system that works, or we're as frustrated as the patient because so far we haven't gotten to that point. In this class, we're going to talk about factors that lead to fistula development. We're going to talk about options for management, including both conservative options and surgical options. And we're going to focus heavily on techniques that the wound care nurse, the ostomy care nurse can use to effectively manage fistulas until they close or until that patient gets to go back to surgery. So let's talk first about what is a fistula and what causes a fistula. Of course, you know what a fistula is. It's basically a hole that should not be there. It's an abnormal communication either between two organs, for example, between the bowel and the bladder, between two loops of bowel, between the bowel and the vagina, or it's an abnormal communication between the bowel or the bladder and the skin. In this class, we're going to focus heavily on fistulas involving the small bowel communicating to the skin, because those are the most common fistulas and because they're the most challenging. Now, in looking at causative factors, it's not surprising that surgery, bowel surgery, is the most common precipitating factor for fistula development. Because when a patient undergoes bowel surgery, of course, they divide the bowel to take out a section, the diseased section, and then they do an end-to-end anastomosis. In the vast majority of cases, those anastomotic lines heal normally. But you can see that if you develop breakdown of this anastomotic line, you would have a hole in the bowel, and you would be leaking stool through that hole into either the abdominal cavity or onto the abdominal surface or into an open wound. Now I'm going to back up here, and I'm just going to clarify that most of the time fistula development involves the anti-mesenteric border of the bowel. I'm actually going to go ahead a slide just to show you what I mean, or several slides. So as you remember, the bowel is attached to the mesentery. The mesentery in turn is attached to the posterior abdominal wall. So the side of the bowel attached to the mesentery is known as the mesenteric border. The side of the bowel that is not attached to the mesentery is known as the anti-mesenteric border. Most of the time, as you can see in this slide, fistula development involves the anti-mesenteric border because the mesenteric border is very well supported by the mesentery. This is actually fortunate because, as you can also see from this slide, the mesenteric border of the bowel points inward toward the abdominal cavity, toward the posterior abdominal wall. The anti-mesenteric border points out toward the abdominal surface. If the leak occurred on the anti-mesenteric border, you can see that stool and bacteria would be leaking into the abdominal cavity, and the patient would be very high risk for peritonitis. Since breakdown almost always occurs on the anti-mesenteric border, that means that drainage projects anteriorly. It leaks out toward the abdominal wall into the open wound. And that, of course, is safer for the patient. Now, when you think about developing a hole on the anti-mesenteric border and stool leaking out, it's always going to follow the path of least resistance. And in a patient who's newly post-op, that path of least resistance is going to be the incisional line. So not surprising that what we commonly see first is incisional dehiscence. So now we have an open wound, and within a couple of days, we have small bowel drainage into that open wound. Okay, let's go back. So breakdown of an anastomotic line following intestinal surgery is by far the most common precipitating factor. Well over 90% of fistulas do occur in patients who have recently had bowel surgery. What else could cause it? Well, let's go back to why is it that the vast majority of people who have bowel surgery do not develop fistulas? It's because most people heal normally. Who's at risk for developing a fistula? People who are not healing normally because of some systemic factor or some local factor. Systemic factors could be poorly controlled diabetes, a patient who's on high-dose steroids and has been for a number of weeks, a patient with multiple comorbidities. Local factors could be tension on the anastomosis or distal obstruction that causes distension at the anastomotic line, or they could throw a little clot to the mesenteric vessel and get ischemia of the anastomotic line. If there's malignancy involving the anastomotic line, any of those things can cause fistula development or can promote fistula development. There's a small group of patients who develop fistulas who have not recently had bowel surgery. Most of those patients have some underlying condition that makes the bowel wall very inflamed and very sticky. When the bowel wall is inflamed, when the outside of the bowel is inflamed, it becomes very sticky. So think about Crohn's disease. Crohn's disease is transmural, meaning that the inflammatory process involves all layers of the bowel wall. That means the outside of the bowel is sticky. That means that that loop of bowel can stick to other organs. It can stick to other loops of bowel. It can stick to the vagina. It can stick to the bladder. Or it can stick to the abdominal wall and create a fistula between the small bowel and the skin. Diverticulitis also is an inflammatory process that is transmural and that results in a sticky outer surface. So occasionally diverticular disease results in fistulas. That's an uncommon complication, but it's possible. Radiation therapy causes inflammation of the bowel wall, and that's another risk factor for fistula development, although it's uncommon. Finally, think about the fact that trauma, a gunshot wound, a stab wound, you can get direct penetration of the bowel wall so that that patient is leaking out into the abdominal cavity. Now, always, that patient ends up in surgery and they try to repair that. But then if that repair does not hold, they end up with a fistula. Okay, now how do we diagnose fistulas? Well, usually we as nurses are the first to notice that there's fecal drainage in the wound or fecal drainage on the abdominal surface. When we notify the physician, of course, they never want to believe that their patient has a fistula. They always have other explanations, which you can very well understand because a fistula is a devastating complication. Most of the time, fistula development has absolutely nothing to do with surgical technique. It is not the surgeon's fault, but it doesn't mean that the surgeon feels any less devastated for his or her patient. So yes, they want to believe it's something else. I always say to surgeons, nurses know poop. If a nurse tells you there's poop in the wound bed, there is almost always poop in the wound bed. So once we come to agreement that indeed there's abnormal drainage in the wound bed and it looks for all the world like small bowel fluid, then they're going to do a workup. In doing the workup, these are the things they have to determine. I'm going to go to the next slide since I can't seem to follow my own slides today. They're going to determine the point of origin and the point of termination. Now we know the point of termination is on the abdominal wall or into the wound bed. But we need to know, well, where does that fistula begin? At what point in the small bowel, for example, does the fistula originate? And they can do that, they can determine that by doing a fistulagram, where they instill radiopaque fluid backwards into the fistula tract. Sometimes they'll do a small bowel follow-through where they give oral contrast or enteral contrast and watch to see where it tracks. Sometimes they do a CT or MRI that can also show point of origin. So we need to know where the fistula begins. We usually know where it is. Secondly, they need to determine whether or not there are any infectious complications. If there's any abscess formation, they will arrange for percutaneous drainage of that abscess, usually CT-guided drainage of the abscess, because we know that until we drain that abscess cavity, we will not get that fistula to close. They need to know whether or not there's any distal obstruction, because if there is any distal obstruction, that has to be corrected surgically or the fistula will not close. So they always do some study to assure patency of the distal bowel. And then finally, they need to determine nutritional status and fluid and electrolyte balance, because when you have an abnormal hole in the bowel, you're losing a lot of nutrients, you're losing a lot of fluid and a lot of electrolytes. And one of the things we have to do for that patient until we get the fistula closed is we have to maintain fluid electrolyte balance, and we have to provide alternative means of nutritional support. Now let me go back and cover the slide that I missed, and that is how fistulas are named and how they're classified. So they're named based on point of origin and point of termination. So you see that in your study notes online or in your hard copy module. If I say that this patient has a colovesical fistula, obviously it originates at the colon, terminates at the bladder, and they're tracking stool and gas from the large intestine into the bladder. They're draining stool and gas through the urethra. And they're very high risk for serious complications, so that would require urgent intervention. If I say the patient has an enterocutaneous, entero means small bowel, cutaneous of course means skin. If I say the patient has a vesicovaginal fistula, the point of origin is the bladder, the point of termination is the vagina, so they would be draining urine through the vagina. So you will of course need to know those terms. And then also fistulas are classified either as high output or as low to mid-level output. This is really important, not only in terms of management, but also in terms of potential for spontaneous closure. Patients who have low output fistulas are much more likely to close spontaneously than patients who have high output fistulas, which kind of makes sense. If I have small amounts of fluid tracking through this fistula opening, then it's much more likely that I can get that opening in the bowel to close. In contrast, if I have a large opening and fluid is tracking through constantly, it's much harder to get that to close. Typically, the cutoff in most texts, with most authors, between low output, high output, is 500 cc's in 24 hours. What we want you to think of is more the relationship between volume of output and potential for closure. And it's an inverse relationship. So as volume goes up, the potential for closure goes down. As you bring the volume down, the potential for closure goes up. So in just a minute, we were going to talk about the principles underlying conservative management when we're trying to get the fistula to close spontaneously. And you're going to hear that a lot of our interventions are directed toward reducing the volume of drainage, because if we can reduce the volume of drainage, we increase the potential for closure. Okay, let's see if I can get back on track here and follow my own slides. I apologize. So when we talk about management of a fistula, there are basically two approaches. Approach number one is conservative management, where we do everything possible to get the fistula to close spontaneously. Option number two is to take the patient back to surgery, remove the section of bowel with the fistula, and do an end-to-end anastomosis. Now, to many of us, especially those of us with a surgical nursing background, we're like, well, just take them back. That sounds like a sure thing. Just take them to surgery, remove the section of bowel with the fistula, and do an end-to-end anastomosis. So why don't we see that done? Why is surgery not the first line of intervention? And there's two reasons. First of all, we have to remember that most of these patients just had surgery just a few days ago. And what happened to that anastomotic line? It broke down. 5 days post-op, your body is much more physiologically stressed than it was at the point of the initial surgery. So how can we expect better outcomes if we take a more compromised patient back to surgery? In most cases, we do not get better outcomes, we get additional fistulas. So surgeons will point out that that initial fistula occurred because of some systemic issue that compromised healing in most situations, and that taking the patient back until we get all of those systemic issues corrected makes very little sense. Here's the other big issue. Those of you who have worked in surgery are probably very aware that the adhesions that form early post-op are very sticky. They literally mat the layers of bowel together. So if you can think of a severe mat in someone's hair, let's say that a child put gum in their hair and you've got all this hair stuck in this wad of gum. And think how many parents have given up on trying to get all of that hair separated from the gum, and instead they just cut it out. Very much the same thing happens in the abdominal cavity. The early adhesions are very, very sticky, and the loops of bowel are literally stuck together as if they've been super glued together or stuck together with gum. To do an effective surgical procedure, you have to be able to go into the abdominal cavity, visualize loops of bowel, separate loops of bowel, cut through adhesions to find the loop of bowel that has the fistula. But if all of the loops are stuck together very tightly, there is no safe way to get into the abdominal cavity, to isolate the loop of bowel with the fistula, to remove that section and do an end-to-end anastomosis. And in fact, what frequently happens is that the patient goes to surgery with one fistula, they come back with multiple fistulas. Because in trying to cut through all of that scar tissue, it's very easy to nick the bowel. So that's why we almost always start with conservative management. If we can get this fistula to close on its own, if we can avoid taking the patient back to surgery, then that reduces the risk to the patient, certainly reduces the risk that we will cause another fistula. When surgery is required, surgery is typically delayed for 3 to 6 months to allow all of those adhesions to soften, so that the surgeon can gain access to the abdominal cavity, can separate the loops of bowel, can find the section of bowel with the fistulous opening, can resect it, and do an end-to-end anastomosis with minimal risk of additional trauma to the bowel wall. So bottom line, what we want you to remember is that almost always our initial attempts are to get that fistula to close spontaneously. If that fails, if we do everything right and the fistula does not close, if we do everything right, the fistula literally turns into a stoma, then we are forced to go to option number 2, which is surgical intervention. Now, in talking about conservative management, I want you to be very clear about the elements of care involved in trying to get a fistula to close spontaneously. I also want you to be very clear about the elements that have to be in place for spontaneous closure to be an option, for conservative management to be an option. And what I want you to notice here is that there is complete separation between the bowel wall and the abdominal wall. At this point in time, if we can collapse that fistula tract, if we can hold it in a collapsed position until granulation tissue fills the defect, we can get that fistula to close. You will see in a few minutes that once the bowel becomes adherent to the abdominal wall, we lose that option. So let's talk about what's involved in trying to get this fistula to close spontaneously. I want you to go back to what we talked about when we talked about volume of output. If we can minimize the volume of output going through that fistula tract, we can increase the potential for closure. So bring the volume down, potential for closure goes up. In talking to patients, when I'm trying to help them understand what we're doing, I explain to them, or I use the analogy, what if you had a garden hose with a hole? And the budget's tight. So instead of going and buying a new garden hose, you're going to try to patch the one you've got. Would you turn the water on full force while you try to apply the patch? Or would you identify the hole, turn the water off, and then apply the patch? Well, of course, you would turn the water off. You want a dry tract when you're doing your patch. Same thing. So how do we minimize the output through the fistula tract? First of all, we minimize what that patient is taking in either orally or through tube feedings, so orally or enterally. Now, as many of you know, for a long time, we just made patients NPO. We stopped output or tried to stop output through the fistula tract. We no longer recommend making these patients totally NPO. We now recommend giving them very low volume oral or enteral feeds, specifically either giving slow drip, high protein formula, or having the patient sip throughout the day on a high protein formula line. Because as you know, when we keep the patient totally NPO, the mucosal layer of the bowel becomes very atrophic and very vulnerable to bacterial invasion. Many patients have developed gram-negative sepsis because we made them NPO, we thinned out the mucosa of the bowel wall, and the bacteria living in their own gut were then able to penetrate the bowel wall and cause sepsis. So the current recommendation is to give the patient about 20% of their total caloric and protein requirements through the gut, either by mouth or by tube feeding. 80% of their nutrients will be given typically through TPN. So we want to reduce oral and enteral intake to reduce the amount of output through the tract. The second thing we can think about is sandostatin. And as you know, sandostatin is a synthetic analog of a naturally occurring GI hormone that reduces the volume of fluid produced every day in the GI tract. So when would I think about using sandostatin? Well, remember, we're trying to get the volume down. So let's say I've already reduced this patient's PO or enteral intake. They're down to less than 400 calories a day. They're getting 300 to 400 calories a day through the GI tract. Everything else is going through TPN. So they're sipping throughout the day. And I've brought their output down from 1,500 cc's at baseline to 750. Okay, I'm much closer to that 500 cc's that we know is associated with increased potential for closure. But I might decide, in conjunction with other members of the healthcare team, it's never just my decision, but the physician may decide to add sandostatin, to do a 2 to 3 day trial of sandostatin to see can we further reduce the output through the fistula tract. So let's say we place the patient on sandostatin. At baseline now they have 750 cc's out a day, and now we get them down to 425. Okay, that's a significant reduction. That's going to help us get that tract to close. Should we keep that patient on sandostatin? Yes. But if the patient is, say, 900 cc's at baseline, we add sandostatin, they go to 800 cc's, that's not a significant difference, and we probably would not continue sandostatin because that small reduction in output doesn't really justify the cost. So when you look at strategies for reducing output through the fistula tract and improving the potential for spontaneous closure, think about oral enteral intake, minimize that. Get it down to about 20% of their nutrients. Think about a 2 to 3 day trial of sandostatin to see if you can further reduce output through the fistula tract. Okay, so now you've met goal number 1. You have minimized output through the fistula tract. You've gotten it down as low as possible. What else? Well, of course, nutritional support, because no fistula will close unless there are the nutrients required to make new tissue. So, of course, we're working with our nutritional support team. They're evaluating the patient. They're tweaking the formula. They're watching their fluid and electrolyte balance, etc. What else can we do? In many centers, they add negative pressure wound therapy. And the concept behind the addition of negative pressure wound therapy is really twofold. First of all, it can help to further collapse the tract. So I've minimized output through the tract. Now I would like to pull the walls of that defect together as much as possible to further reduce output. Also, if I can kind of pull the walls of the tract together through negative pressure and kind of hold them in that position, then it takes very little granulation tissue to fill that defect. So if I can take the defect from here to here, you can see that that's a much better situation in terms of trying to get this to heal spontaneously. So reason number 1 for using negative pressure wound therapy, hopefully we can reduce the gap between the sides of the defect. Pull the defect together, hold it there, so that less granulation tissue is required to seal the defect. Secondly, as you know, negative pressure wound therapy is very helpful in establishing a well-vascularized wound bed and initiating collagen synthesis. So if negative pressure wound therapy can do that for this patient, if it can help get that wound over the hump to making granulation tissue to seal the defect, and if it can kind of pull the walls together to minimize the defect, that can be very helpful. Now, we also know that negative pressure wound therapy is fairly costly, and we know that if negative pressure wound therapy is not used correctly, it can make things worse instead of better. So we're going to go through some of the guidelines for using negative pressure wound therapy correctly. Okay, in most centers they're using BAC, but the same guidelines apply whether you're using KCI's BAC or you're using another company's negative pressure wound therapy system. Many times we're using a foam-based system. If we're using a foam-based system, we want to avoid placing that open pore reticulated foam in direct contact with the wound bed. That's always contraindicated in a fistula patient, and I'll explain why in just a minute. And secondly, we want to avoid placing gauze or catheters or foam down into the fistula tract because we're trying to close the tract, not hold it open. So as you can see here, we have white foam shown. You want to place white foam in direct contact with the wound bed if you have white foam available. Alternatively, you could use a silicone-based contact layer like Mapitel or Versatel, put that across the wound bed and then put your foam on top. If you don't have that, you could use something like Adaptic, place Adaptic across the wound bed and then place your foam on top. Why do we say avoid placement of that open cell reticulated foam directly on the wound bed? Because typically in a patient with a fistula, you have a very thin layer of tissue covering the loops of bowel. If you put that open cell foam right on top of the wound bed and allow the tissue to grow into the foam, then when you go to remove the foam, it's very easy to take off that thin layer of covering tissue and to actually unroof the bowel. And there have been multiple situations in which inappropriate use of negative pressure wound therapy actually caused fistulas. When I have a patient who has a fistula, what do I know? They're very high risk. Do I want to do anything to increase their risk of further fistula development? And of course the answer is no. So you always err on the conservative side. Always use either your non-porous, non-reticulated soft white foam as your base and then black foam on top, or put your silicone adhesive contact layer and then your foam, or Adaptic and then your foam. You don't want to be writing or telling one of the horror stories that have occurred related to inappropriate application of the porous reticulated foam directly on the wound bed. So you put down the appropriate base layer, then you put your black foam on top, and then you regulate the pressure setting. Now typically we start at -150. And what are we looking for? We're trying to collapse the fistula tract. So we look to see, are we still getting small bowel fluid going through the tubing? If I start at -150, I come back a couple of hours later, and I've still got small bowel contents running through the tubing, I'm going to go up to a -175. If that stops the small bowel fluid, and now all I see is serous sanguinus, I'm going to hold there. If I come back and I still have small bowel fluid running through the tubing, I'll go up to -200. That's the highest level that we can go to currently. So you regulate or you titrate your negative pressure between -150 and -200 with the goal of minimizing or eliminating small bowel fluid tracking through the tubing. Now, if I'm able to either eliminate the small bowel fluid or significantly reduce the amount of small bowel fluid, then I'm going to continue negative pressure wound therapy. I'm going to maintain continuous suction to hold that defect in the more closely approximated position and to support granulation tissue formation. Typically for about 3 weeks, and then we'll usually start backing off the pressure to be sure that our fistula tract is indeed well closed. Now, if I have gone up to -200 and I still have high volume fluid tracking through the tubing, I have to rethink whether negative pressure wound therapy is a good approach for this patient because it's a very expensive way to manage drainage. So just to throw out some sample numbers. If at baseline, after I did everything I knew how to do with controlling oral enteral intake, adding sandostatin, I had 800 cc's a day. Okay, so I've gotten it down from 1,600 cc's a day to 800 cc's a day. That means I'm pulling the edges of the defect together. I'm reducing the volume of output. Now if I can add negative pressure wound therapy and I take it from 800 to 300 a day, should I continue? Yes, that's a significant reduction, okay? But if I take it from 800 to 600 a day, that's not a significant reduction. And then you have to really rethink, is this valid therapy? So just to recap, the principles of conservative management. First of all, reduce oral intake to about 20% of total nutrient intake, and make sure the patient's sipping throughout the day or that you're doing slow drip enteral feeds. Secondly, make sure that the patient is getting adequate nutritional support through TPN or PPN. Think about sandostatin, at least doing a trial run to see if you can further reduce output with use of sandostatin. And then finally do a trial of negative pressure wound therapy. And your goal throughout is to see how much can I reduce the output while maintaining nutritional support. Those are the key principles of conservative management. Okay, so I think we have already talked about this. We did. Now, what are the indicators that spontaneous closure is probably not going to work for this patient? And we've alluded to this. I'll go back through this, and there's one thing we need to focus on in detail. First of all, the higher the output, the less likely it is that we'll be able to get this fistula to close. Now, you look at output at baseline, and it's certainly a reflection of the size of the defect, but I'm focused much more heavily on output once I've done everything I can to reduce the volume of output. So let's say at baseline, output's 1,400, and I'm like, well, that's not very good, but let me drop their PO intake to 20% of their total nutrient intake for the day. Let me do a 2 to 3 day trial of sandostatin to see if that further reduces output. Let me do a trial of negative pressure wound therapy to see if I can pull the edges of the defect together and further reduce output. So if after all of those things, I've gone from 1,400 a day to 550, 600 a day, it's like, you know what? I'm not giving up on this patient. This patient may very well be able to close this defect spontaneously. And of course, we never give up on patients, but you know what I mean. In contrast, if I start out with 1,500 cc's and I start looking at the patient's PO intake, well, they're already taking in very minimal amounts, so I can't really do anything significant with that. I add a 3 day trial of sandostatin, takes them from 1,500 to 1,250, not a significant reduction. I try negative pressure wound therapy for 3 to 5 days, and I take them from 1,250 to 1,000. Still not a really significant reduction. That's a lot of fluid going through the tract. So you see how you have to balance and stand back and say, is this likely to get us where we want to go, or are we adding cost unnecessarily, restricting the patient's activity unnecessarily? Okay, so size of the fistula tract, volume of output, and volume of persistent output after you've done everything you can to get it down to 500 or less. Notice what's in bold: pseudostoma formation. If that fistula turns into a stoma, it will never close spontaneously. Once that fistula stomatizes, you already know that patient is going to require surgical intervention to close the fistula tract. So I want you to be very clear about what we mean by pseudostoma formation, by the fistula stomatizing. The first thing I want you to see is what's happening anatomically. So the slide I showed you previously, you saw complete separation between the bowel wall and the abdominal wall. And I said at that point you do have the potential to get that tract to close. Now look at what's happened when you get pseudostoma formation. Now the bowel wall has become adherent to the abdominal wall. The mucosa turns back on itself to form a stoma. And when you look in the wound bed, you literally see stomas. Or, look here, even clearer. See the stomas in the wound bed? See the stoma in the wound bed? Going back to what's going on anatomically. Think what happens when a surgeon makes a stoma. He or she makes an abdominal incision, grabs the bowel, attaches the bowel to the abdominal wall, which creates a permanent opening into the gut. So you never say to your ostomy patients, hey, check every morning to make sure your stoma is still there, and call me if it's not. No, you would never say that, because once you attach the bowel to the abdominal wall, it's a permanent opening. Once the bowel has become adherent to the abdominal wall, it's a permanent opening. So pseudostoma formation changes everything. If I take off my negative pressure dressing and I see that my fistula has stomatized, I know that spontaneous closure is not an option. I know that surgical closure will be required. I need to notify the surgeon. We should continue nutritional support because the patient's losing a lot of the nutrients through the stoma, through the fistula. But do I need to keep that patient on a very, very restrictive diet? Is it going to make any difference? Is it going to help that pseudostoma go away? No. So once that happens, we have to reevaluate our management plan. We'll come back to that. Other risk factors for failure to close: areas that have been radiated in the past. It's very unlikely that we will get that fistula to close. Malignancy in the area, very unlikely that we'll get the fistula to close. Active infection, undrained abscess, and your comorbidities. Okay, so when I'm assessing a patient with a fistula, every time I do the dressing, every time I go to see the patient, I'm looking for several things. First of all, when I pull their chart, I'm looking to see what was the volume of output through the fistula tract over the last 24 hours, and did they have any output through the distal bowel? Like, did they also have output through their stoma? That's a good sign. If there's decreasing output through the fistula tract, increasing output through the stoma, that's good. If I have a patient who doesn't have a stoma, they just have a fistula, I'm going to ask them, are you having bowel movements? Are you passing stool rectally? If they have increasing output through the rectum, decreasing output through the stoma, through the fistula, that's great, because it means that gradually the fistula tract is closing and forcing the stool to go distally. Okay, because the fistula is kind of like an alternative pathway. It's like a Y in the road, so that the stool can either go here or it can keep going on the main road. As this tract gets narrower and narrower and narrower, the stool is much more likely to go distal. So I'm looking to see, is there a reduced amount through the fistula tract? I'm also looking to see, is there increased output through the distal bowel, either the stoma or the rectum. Any evidence of foreign body, but most importantly, evidence of mucosal eversion, evidence that that fistula has stomatized. So I want you to be very, very clear about what we mean when we talk about a fistula stomatizing or pseudostoma formation. Now I will tell you, pseudostoma is not an accurate term because it sounds like it's not a real stoma, and it is. It's just a spontaneously occurring stoma. That's really how we should refer to it, as a spontaneously occurring stoma as opposed to a surgically created stoma. So, if the patient fails conservative management, they're going to be forced to get in line for surgical closure. There are two indications that the patient has failed conservative management. One is that the stoma, I keep saying stoma, one is that the fistula has stomatized, that you have pseudostoma formation. So the bowel has become adherent to the abdominal wall. The only way to fix that is surgically. The second indicator that surgical correction will be required is I've had the patient on this conservative management program for 8 to 12 weeks where we've controlled output, we've maintained nutritional support, we've used negative pressure wound therapy, and we've made no progress. Obviously, if It was going to close with that management plan. It would have closed within that time frame, so now it's time to think about surgical closure. So, when's it required? We talked about that. Back to the fact that they're not going to take the patient to surgery immediately. They're going to wait for 3 to 6 months until all of that scar tissue, all of those adhesions in the abdominal cavity soften, so that they optimize that patient's potential for successful resolution. If they go in prematurely, they're likely to create more problems. So we have to be able to explain that to the patient. Because you can imagine, if you were the patient, you would not want to be talking about, let's see, this is February, maybe May, maybe June. That would be very hard to hear. You have to be able to help them understand why we're waiting. And then you have to be able to help them manage in the 3 months, 4 months until surgical correction can be performed. So interim management, now we've shifted gears. We're no longer trying to get the fistula to close because it's not going to. We want to maintain nutritional support, so yes, we'll keep the patient on TPN. We want to come up with a cost-effective, patient-friendly way to manage the stool, the odor, to protect the skin. Okay, so containment is a huge issue. But what about keeping them NPO or significantly restricting their output? No, that is not necessary. We already know that surgical intervention is going to be required. So there's nothing to be gained by keeping this patient on a very restricted PO intake. To say all you can have is these 2 nutritional shakes that you sip throughout the day. No, you can liberalize their PO intake. Now, do you want them eating whatever and whenever? No, because it's going to make it much more difficult to manage the fistula and contain the drainage. So what you want to say to them is, yes, you can eat. You need to limit your intake because everything that you eat increases your output and makes it harder to keep a pouch on. But I want you to be able to eat for pleasure. So if your family's going out to dinner, can you go out to dinner with them and eat a small amount? Yes. If you're having a special meal, can you have a small amount? Yes. If you're just craving something, can you have a small amount? Yes. Just try to minimize the volume. Don't overeat because everything you eat is coming through that tract and making it harder for you to keep your pouch on and to protect your skin and to bleach. Okay, so we've already talked about when we do surgical closure, what they're going to want to do is they want to go in there, they want to remove the section of bowel with the fistula, doing end-to-end anastomosis. This time, we want all systems go to get this end-to-end anastomosis to close. And we already talked about why it's going to be delayed and how important it is for you to be able to explain that to the patient. Now let's talk about enteral management, because once you have a patient who has failed conservative management, almost always we discontinue negative pressure wound therapy because that's a very expensive way to manage drainage. So typically we discontinue negative pressure wound therapy, and now we have to come up with another way to manage all of this output. So we're going to go through what the options are. Option number 1 is to use standard pouching, typically using wound pouches. The advantage is this is usually pretty readily available. There's a number of features of wound pouches that make them particularly helpful in this situation. So let me just show you a few things. First of all, wound pouches, fistula pouches come in all sizes. They come in very small sizes. Why would you ever need anything this small? How is that going to help with the fistula? Well, think about your patient who has an esophagostomy. They've had head and neck surgery. They had to have the esophagus connected to the skin on the neck. Think about the fact you make 1,500 cc's of saliva before you ever swallow anything. So they're going to have very high volume output. Absolutely miserable if we manage them with gauze and towels and things like that, because they're wet and slimy all the time. But you can't put a big pouch on their neck. It's not going to fit. So what we do is we take a pediatric fistula pouch that's very conformable and we size it to fit around the opening in the neck. Notice that there's a spout. So we connect tubing to the spout, run it underneath their underwear to a leg bag. So saliva and whatever they drink comes through here, through the tubing, into the leg bag and is emptied there. And then you can, of course, conceal it with a scarf or whatever. So there are some very small pouches. Then for patients who have relatively small wounds, there are relatively small wound pouches. There are mid-sized pouches. There are large pouches. There are pouches that run from side to side, as well as those that run top to bottom. There are a couple of features that you're always looking for with a wound pouch. And the first is a spout. You need to have a spout so that you can connect it to bedside drainage or to wall suction, because a lot of these patients will have such high volume drainage that the staff will not be able to get there often enough to keep this drained. So you want to be able to connect them up. So that's one important feature. The second important feature is that most of these have an access cap. It means you can open the pouch and access the wound, visualize the wound, provide wound care, whatever. That's very helpful because it means I can go in, I can open this up, I can clearly and closely inspect the wound. If I need to add any protective paste along the margins, I can do that without taking all of this off. But the number one reason is to keep other team members from taking it off. Because you know your luck. You just spent 2 hours getting it on, and you go down the hall to take care of someone else, and who comes in? The surgeon. And what do they want to do? They want to look at the wound, so off it comes. You use a pouch with an access cap. You put a little sign on the cap that says, "Please do not remove, open trap door." Still not enough because you know we don't read. We can read, but we don't read. And so they're still likely to remove it. So you tell the patient, you see this little trap door? You know how long it's taken us to get this on? I know you don't want to go through that again today. The patient's like, no, I don't. Okay. So when your doctor comes in, just hold your hands over your pouch. And when he says, I want to check your wound, just say, hey, look, there's this little trap door. It took a long time to get this on, and I don't want to go through that again. So can you just open that trap door and not take it off? Our patients are very good at protecting their pouches. Okay, so if you have a patient who's failed conservative management, your first thought is, can I manage this patient with a standard wound pouch? Can I find a wound pouch that's large enough? The cutting area is large enough. Do I have a pouch with a spout? Do I have a pouch with a trapdoor? Now, in looking at strategies to improve your seal and to keep it on and maintain adhesion, there's two techniques that are very, very important. And the first is make sure that when you cut the opening out in the pouch, cut it wider than the wound. Make sure that the opening in the pouch is at least 1/4 to 1.5 inches wider than the opening in the skin. I'm going to show you why. If you look here, you can see that all of these pieces of barrier come away from the wound. Think about the fact that the wound edge is wet. If you size the opening in the pouch to come right up to the edge, and the pouch edge is touching the wet edge of the wound, it will always lift, and then you will get undermined. So if you size the opening larger so that you're coming back to flat, dry skin, you have a much better chance of getting it to stick. Now, I know you're saying, well, what about that exposed skin? We're going to cover that exposed skin with paste. So we do have to protect the skin, but we don't want our pouch coming right up to the edge. Okay, so here's your pouching procedure. You're going to treat any damaged skin with crusting. A lot of you know what that is. For those of you who don't know what that is, you can take your ostomy powder and you can sprinkle your ostomy powder onto any damaged areas of the skin, and it will form a gummy protective layer like an ultra-thin hydrocolloid. And then you can open one of your little plasticizing protective white skin prep, Cavalon, Sure Prep, Hollister Skin Gel, all care, doesn't matter. And you're going to blot over the powder. And it looks like you're picking all the powder up, but you're not. When it dries, you'll be able to see that you have a plastic film on top, and underneath you have that protective layer of powder. So now that damaged skin is protected, but on top you have a plastic film that allows you to attach your pouch, just what you need. So clean your skin, treat any damaged areas. As we said, make a pattern of the wound, cut the opening so that it clears the edges of the wound by at least a 1/4 inch. Okay, now we talked about using paste to protect the skin. You can also use your paste to fill any defects. Like if you have a little dimpled area, you can use paste to fill that. Because the fistula will not stop draining while you're trying to get your pouch on, the best approach is get your pouch ready and lay it to the side. So I've cut out my pouch, okay? I've taken the paper backing off. I've got it all ready to go, and I've laid it to the side. Now I can use tampons, and I can hold tampons over, or I can even, when I have a stomatized fistula, I can even put the tampon into the stoma. That will control drainage for at least a few seconds. So I put my tampon in, clean my skin, swap out my tampon, treat any damaged areas, trade out my tampon, put paste to fill any defects. Then what we recommend is as soon as you get the surrounding skin treated, protected, take your pouch, swap out your tampon, and now put your pouch down. And now you can go inside and you can add your protective paste to the exposed skin a little bit at a time. So I can swap out my tampon, add paste. Swap out my tampon, add paste. And that allows you to do this procedure by yourself, as opposed to having someone else there to control the drainage with the tonsil tip suction or whatever. The alternative is to put down your protective paste first and then put the pouch on top. Here's the problem. Let's say I put down my paste first. Now, as my drainage washes over the paste and as the paste gradually washes away, can you see that the drainage is going to go up under the edge? In contrast, if I stick the pouch down directly to the skin and then put paste on top of the edge, even if my paste washes away, my pouch is still stuck to the skin. So our recommendation is get your pouch ready, lay it to the side. Have a stack of tampons that you can use to control fistula output. Hold a tampon in, clean the skin, dry the skin. Swap out, treat any damaged areas. Swap out, fill any little defects with paste. Swap out, put on your pouch. Swap out your tampon, add paste to the edge, swap paste till you get it all done. Okay, that works very well. And obviously something weird happened with my slide here, but this is supposed to remind you to wet your finger when you're applying the paste. And we'll show you this on site, because if your finger is wet, you can literally sculpt the paste. And when you're applying the paste, you do not want to create a retaining wall, you want to create a ramp. So the paste should be very flat around the stoma. The stoma should always protrude above the paste. And the paste should never be higher than the stoma itself, than the fistula opening itself. Okay? We'll practice this on site. Well, what if you can't get a pouch to work? What if it just keeps coming off, or you have a really big wound and none of the pouches that you have in central supply are large enough? Are there other procedures that you can use? What are your other alternatives to managing this fistula? And a very simple approach to managing a fistula in a patient who is bed-bound or chair-bound is what we call the closed suction procedure. Very simple. You can teach your staff to do this. It usually takes about 10 minutes to do this procedure. So what you're going to do, you see here, this patient had a fistula in an open wound. The patient was in ICU and was bedbound. Now these nurses elected to put a protective bead of paste all the way around the wound. You don't even have to do that. You could just protect with skin prep or sure prep or whatever. So you could either do just your standard skin prep type protection, or you could do your bead of paste. Then you line the wound bed with several layers of damp gauze, because as you know, you never want to put a suction catheter in direct contact with the wound bed, because when you activate the suction, it will pull against the wound bed and cause trauma. So we always protect the wound bed before we place our suction catheters. One layer is usually not enough. You usually want about 3 or 4 layers of damp gauze. Non-woven gauze is better than woven. In this slide, they used woven gauze like Cling, but it would be even better to use, they use Curlix, excuse me, this is Curlix. It would be better to use non-woven gauze like Cling or Conform. Because as you know, woven gauze like Curlix can leave fibers in the wound bed, can become adherent to the wound bed because of that very open weave and loose strands. But your non-woven gauze like Cling or Conform, much softer, much less abrasive to the wound bed, no risk of leaving fibers behind. So you put down several layers of protective gauze, and then you place your suction catheters. Now I wanted to explain something that's different about this slide. In this particular case, the surgeon wanted to instill an antibiotic solution every 8 hours. So what they did was they fed their installation catheter from the top down, and then they placed their suction catheter below the fistula, which was right here. So of course you know you would always place your suction catheter below the point where the fistula empties. Sometimes if you have a very large wound or very high output, you'll actually place 2 suction catheters, either like one a little bit above the other one or angled a little bit. Most of the time what we do, we go to central supply, we find the largest urethral catheter they have, or suprapubic, doesn't matter. What's the largest catheter they have? And we cut off the tip so that we have better drainage. You can also cut additional little holes down the side of the catheter just to give you additional drainage pores. Now you take several layers of damp gauze and you put them on top of the catheter to stabilize the catheter. Also, it assures that when you add your transparent adhesive drape, that drape doesn't cover up the suction holes on the catheter and stop the suction effect. So you put down gauze to protect, place your catheters, gauze to stabilize, and then you're going to place transparent adhesive drape over the entire thing. If you have someone to help you, you can work together and you can put it down as one piece. If you're doing it by yourself, which we frequently are, you can apply it in strips. And of course, you're going to wrap around the suction catheter to get a very good seal. Then You just connect the suction catheter to wall suction. You control the drainage by suction. You know exactly how much drainage you have because you empty the canister at the end of every shift, and you change it once or, typically every 1 to 2 days. Minimum of 3 times a week. Very simple, very straightforward, very easy to teach. Okay, a couple of other procedures I want to go over. The trough procedure. You will see this in your online materials, and you will see this in your hard copy module. This is one of those procedures that's very hard to understand until you actually get to do it, and you will do it when you come on site. We're also working on a YouTube video to show you how to do it, but it's not going to make a lot of sense till you come on site. So I'm going to walk you through it. I'm going to explain it. If it still doesn't make sense, don't worry. You will get to do it, and it almost always makes sense once you get to do it. So when do you think about doing the trough procedure? First of all, it works only for fistulas that drain into open wounds, because essentially what you're going to do is you're going to cover the entire wound with transparent adhesive drape, and then the bottom piece of adhesive drape will have a big hole and there will be a pouch on top. So you're going to essentially turn the wound into a trough and force the drainage all the way down to the bottom and into the pouch. So you cannot do this if the fistula empties directly to the abdominal surface. It's intended only for fistulas draining into open wounds. Very easy to use for large wounds and for irregular surfaces. That's actually how this procedure got started, because Chris Martin, who was a woundostomy nurse in Florida, had a lot of patients with fistulas and was having trouble keeping a standard pouch up. And so we started thinking outside the box and came up with this very innovative and very effective technique that he named the trough procedure. I think you should have named it the Chris Martin procedure, but he did. Okay, so easy to use for large wounds, irregular surfaces, and you know you can modify it however you need to. So you get this on, you can add suction so that when the patient's in bed, the drainage is being managed by wall suction, and then when they're up walking around, the drainage goes into the pouch. So here's the basic steps of the procedure. The first concept is, instead of using a solid piece of barrier that is very likely to lift at different points, Chris chose to use overlapping strips of barrier. Each strip now has the ability to flex, so it's very much like shingles. You think when you put on a shingle, you put the base shingle, another shingle, another shingle, another shingle. So every shingle overlaps the previous shingle. That's exactly what you do here. So you put down a U-shaped piece of barrier or hydrocolloid at the base of the wound, and then each subsequent strip overlaps. So I'll go here to here and here to here, here to here, here to here. So you put your barrier down one piece at a time, starting at the bottom. I know that in this slide, it looks as if the barrier strips come right up to the edge of the wound, but that's not true. They were cut to clear the wound. It's just that we have already applied paste as our caulk, and therefore it looks as if the barrier comes up to the edge of the wound. So you keep applying barrier strips until the entire surface is covered. Now again, I wanted you to get the concept of these shingled barrier strips. I'm hoping that you can see here that each strip overlaps the previous strip. In this particular one, you see them using a tongue blade to help smooth paste. So you overlap your barrier strips. You use very flat paste. Remember, you never want to create a retaining wall. You always want a ramp for the drainage to follow. And we're going to go over that when you're on site. At the end of this step, all of the peri-wound skin is protected. And you can see that. All the peri-wound skin is protected. Now you have to get your bottom strip of transparent adhesive dressing and pouch ready. Doesn't matter whose strip you use, whether you use oxide or you use negative pressure wound therapy drape or you use Tegaderm or BioClusive, doesn't matter. But what you want to do is you want to create a hole in that transparent adhesive dressing and pouch so that when the drainage comes down to the bottom, it can flow right into the pouch. There's basically two approaches. You can either cut a big hole in the drape and then a big hole in the pouch and then put them together. When you come on site, what we'll have you do is cut a starter hole in the drape, put your pouch and drape together, and then enlarge the hole. And your goal is that the opening in that drape pouch combination should be wider than the base of the wound. So let's see if I can show you that. So if this is the base of the wound, when I'm cutting the hole in my oxide pouch combination, it's got to be larger than the base of the wound, okay? So here's my pouch. And the hole in my pouch clears the base of the wound. And that's just to assure free drainage. And again, if this is making zero sense to you, don't worry too much because you're going to get to do it, and that's when it's going to make sense. So once I get that bottom piece of transparent adhesive dressing and my pouch ready, I go in and put that piece down. Now any drainage that comes down will flow into the pouch. And then I do overlapping strips of adhesive drape all the way up the wound to cover the wound. There are some similarities to negative pressure wound therapy. With negative pressure wound therapy, we seal the entire wound with drape, and we use suction to carry the drainage from the wound to the canister on the wall or in the machine, okay? Here, we use drape to seal the wound, but the bottom piece of drape has a hole and a pouch stuck on top so the drainage goes into the pouch. So it's gravity drainage instead of suction management of the drainage. So are you sitting there scratching your head like, I didn't get any of that? Don't worry, you will. Bottom line, you protect all of the peri-wound skin with overlapping barrier strips. You're going to seal the entire wound with transparent drape, just like you do with negative pressure wound therapy. The bottom piece of drape has a big hole, and on top of the hole is a pouch. You'll get to do it. Okay. Now, I'm going to just briefly go over a bridging procedure. You may never need to do this, but on the other hand, many of us have had to do this. The bridging procedure is something that you can use when you have a very long wound and one area of the wound, the most distal area of the wound, has a fistula. And that area needs to be pouched, but the rest of the wound just needs moist wound healing. We will also go over this when you come on site. So let me tell you about this patient. She was post-liver transplant. She had a wound that started on the right mid-axillary line and came all the way across her abdomen to the left mid-axillary line. She had a fistula, a biliary fistula that was right here, so very close to the end of the wound on the right. The rest of the wound just needed moist wound healing, but that fistula was draining about 600 cc's a day, so she was always wet. And the nurses and the patient were so frustrated because they were changing dressings all the time, changing her gown, changing her linens, and they were like, can't we do anything? So my partner and I were standing at the bedside and we're thinking, well, we have a pouching surface here and here and here. We just need to somehow fill in the wound right here so that we can create a pouching surface, that fourth side. And the nurses were like, well, how are you going to do that? We thought, well, maybe we could use hydrocolloid wedges and literally build a bridge, fill the wound with hydrocolloid wedges at this point. So you can see that we're putting hydrocolloid wedges down into the wound. We started at the base of the wound, which was very narrow, and did a narrow strip, and then a slightly wider strip, slightly wider, slightly wider. This is about 4 strips in. We're getting very close to reaching the surface of or to matching skin surface, okay? So here we're essentially at skin surface. And the first time we did this, once we got to this point, we took a wide hydrocolloid strip and we went all the way across. And we attached a pouch. And it lasted 2 hours and fell into the wound. So, we came back and we modified our approach. And we brought all of our barrier strips, we filled the wound right in this area with barrier wedges till we got to skin surface. But then we added 2 additional strips so that we came up to skin level, but then we built it up a little bit. We added some additional strips so that we had a little bit of a pressure dressing effect. And I think you can see it in this slide. So we built it up to skin level, we added a couple of barrier strips beyond that, and then we took a cover strip that went all the way from here, all the way across, and then we troughed it. And again, I think you can see the increased thickness that we had built it up a little bit above skin level so that we had a little bit of a mechanical retention effect. That worked. Now, we were very concerned with that very soft bridge, with that slight pressure effect. Would that cause any problems? Would that cause any problems with healing of the underlying wound? So we changed it after 24 hours. The wound bed looked fine, but what we did was we changed this out every 2 to 3 days, and we changed the position of the bridge. You might not ever have to do this, but if you do, it's a very helpful technique. I've seen in multiple presentations at conferences since then, when clinicians are presenting challenging fistula situations where they frequently do this. They divide the wound into 2 areas so that they're pouching the area with the fistula, and then they're doing moist wound healing for the rest of the wound. So here's the patient. You can see we troughed it. You can see it's working. It's going into the pouch. She could lie supine. She could sit. She could stand. She could walk. She could sit in the chair. She could not turn to the left because it would obviously tunnel under. Now there is another option other than using a series of hydrocolloid strips and wedges. You could also use the white foam if you have access to white foam from negative pressure wound therapy. And you could use wedges of white foam, fill the wound, then take your hydrocolloid barrier strip and put it all the way across. We'll talk about this again when you're on site, so you'll have a chance to ask any questions. Just a few more things that we wanted to cover for you. You may sometimes be consulted for women who have either a rectovaginal or an intravaginal fistula. And management for the 2 is totally different. So you think first about a woman who has a rectovaginal fistula. And this can occur post-vaginal hysterectomy, when they inadvertently create a pathway between the vaginal vault and the rectum. Now, many of these women end up with a diverting colostomy to allow that fistula tract to heal, and in that case, you'll be working with the patient in terms of stoma management. But some women are either not surgical candidates or they elect not to have surgical correction. And you might be asked, well, what should we tell this woman? How should we help her manage? So go back to the fact that when you have a rectovaginal fistula, you have essentially formed stool. You have a narrow tract between the rectum and the vagina. In managing that patient, your goal is to minimize any contamination of the vagina. You want to minimize the amount of stool tracking from the rectum to the vagina. And you want to avoid any enlargement of that fistula tract. And it all goes back to stool consistency. She needs perfect poop, okay? She needs poop stool that looks like smooth sausages. Number 4 on the Bristol stool scale, which if you haven't seen it yet, you'll see it when you come on site. What's the advantage of having that soft formed stool? Well, first of all, formed stool will not pass through that narrow fistula tract. Liquid stool will, mushy stool will, little pellets will, but soft logs will not pass through. So you minimize vaginal contamination. You keep stool out of the vagina. Now, can she still get bacteria tracking through? Yes. But is she going to get active stool passing through? No. Secondly, when stool is soft and formed, it's very easy to eliminate without straining. And if you eliminate straining, you significantly reduce the risk that that fistula tract will enlarge. So you focus totally on, number 1, getting her fluid intake where it should be, 30 cc's per kilogram up to about 2 liters a day. And then you add a bulking agent. Frequently we recommend Citracel because you don't get as much gas formation with Citracel until her stool is smooth, soft formed. Smooth, soft logs, okay? Now, if she's having any problems with odor, we can recommend an antimicrobial vaginal gel like Trimisan. She can wear a little pad, but the risk of having any significant drainage go through the vagina is very, very limited. Enterovaginal, totally different. Vesicovaginal. So enterovaginal, these are usually women who have had extensive pelvic malignancies. They're frequently end of life. The bowel, the small bowel, has become adherent to the vaginal vault. Now they have ileostomy type stool, fistula type stool, tracking through the vagina all the time. So they're always wet, they always feel dirty, they always feel as if they smell, and their skin is a disaster. Vesicovaginal, also very difficult. That's bladder to vagina. The advantage is urine and not stool. So are they always wet? Yes. Do they have as many problems with odor? Not nearly as many as someone with stool, and not as many problems with skin breakdown. Doesn't mean that there's no odor. There is. Doesn't mean there's no issues with skin breakdown. There are. So what can we do? Staff will put people in briefs because that's all they can think of to do, and then they're literally holding the urine, holding the stool against the skin. So I want to introduce an alternative. If you have a stenotic, a very narrow vaginal vault, let's say you come in, you use lidocaine jelly, xylocaine jelly, you wait till it takes effect, you do a digital exam to see how wide is the vagina at the base, and let's say it's very narrow, barely 1 to 2 finger breadths at the base. Then you can go downstairs or you can go to your central supply and you can get the largest balloon tip catheter you have. And you can literally insert that balloon tip catheter into the vagina and inflate the balloon. And what will happen is the balloon will occlude the vaginal opening and the stool or urine will track through the catheter, and then you can connect the catheter to a leg bag. It's going to be very much like managing fecal incontinence with an internal bowel management system like FlexiSeal or ActiFlow or DigniShield. Will it totally eliminate leakage? No. But you know that when you inflate the balloon on an internal bowel management system, it pretty much blocks the anal opening and then forces the drainage through the catheter. What we're trying to do is block the vaginal opening, close the door, and then right through the door, insert a catheter so that the drainage is forced out through the catheter to the leg bag. But sometimes you'll have women who have a fairly wide vaginal vault, and so when you do that digital exam, you'll find that the vagina, that the opening, the introitus, is 2 to 3 finger breadths. And that's larger than the balloon on your catheter tip balloon. So then what can you do? So I will show you this when you come on site, and you'll get to actually handle this, but let me just show you a basic concept. You can take a baby nipple, and you know baby nipples come in different sizes. So you've got your kind of standard baby nipple like this. Then you have your baby nipple that has a larger base, the baby nipples that are intended for use with disposable nursers. So you see here, this baby nipple is right at 3 finger breadths, okay? So if my exam showed that the vaginal opening at the introitus was 2 to 3 finger breadths, this would be perfect because I need to block the opening at the introitus. So this is going to sit right inside the vagina, and it's going to block the opening. And then what I need to do is I need to feed a catheter through so that the catheter sits right at the top of the nipple. So now I've closed the door, blocked the opening, but I have a catheter sitting there so the drainage will go through the catheter and to a leg bag. This happens to be a mushroom type catheter, but it doesn't have to be a mushroom type catheter. It can be any large catheter, and you can cut off the tip. So then I can tape the catheter to the baby nipple. I've also used nipple shields, and somebody suggested that you could use a diaphragm, anything that you can use to basically block the vaginal opening. If I was going to insert this, I would lubricate it. Those of you who have been taught how to do speculum exams, you know you should always put pressure down against the posterior vaginal wall, tuck it in, and then tuck just a little bit, little bit, little bit, little bit, being very gentle. These women have been through a lot and they're in a lot of pain. Till I get past that muscle sling, and then I can just pull it back gently. And then I connect it. Now, they will still have some leakage, but I can protect the skin with a moisture barrier ointment. I can have the patient wear snug panties and cut a little hole so I can feed this through to help hold it in. If it comes out, all they have to do is untape it, wash it, dry it, tape it back together, and reinsert it. Patients can even learn to do it themselves. So I wanted you to have that basic concept. As long as you have the basic concept, you can work with different materials to make it work for your individual patient. And then the last thing I wanted to mention is, what do you do when you have a patient with an unpouchable fistula? We consider a fistula to be unpouchable when no one can get a pouch to stay, but we also consider them to be unpouchable when you are the only one who can get a pouch to stay. And it takes you 1 to 2 hours, and it stays on 24 hours. So then what happens when you're not there? What happens if the patient goes home? If you're in home care, what happens if you're off that day? So you should always have a fallback position that your staff can use for an unpouchable fistula. This is what they should use when a patient comes in. If they can't make a pouch work, it's what they should use if a pouch comes off and you're not there. Because bottom line, your goal is protect the skin, manage the drainage. So it's very simple. You can protect the skin with a thick layer of zinc oxide ointment, over the counter or one of the products that you stock in an inpatient setting. So thick layer of zinc oxide paste. Then you're going to use a diaper with super absorbent polymer. So it could be a baby diaper, it could be an adult diaper, it depends on the size of the wound. If your diaper is larger than the wound, then you're going to cut it down to fit the wound. If you have to cut it down to fit the wound, then you have to take the sides so that those superabsorbent polymers don't out into the wound, okay? So now you put your diaper into the wound. Very important, you have to cover the diaper with something that creates slight pressure, because you have to hold the diaper against the wound bed to force the drainage into the diaper. Otherwise, it just drains out and under. So for children, we frequently will put the diaper over the wound bed and then secure it with stretch net. For adults, we frequently secure with a binder, something that puts pressure. Then we tell the patient or ask the staff every 1 to 2 hours, go into the room, open the binder or roll down the stretch net, remove the old diaper square, reinforce the zinc oxide as necessary, replace the diaper square, close or pull the stretch net back up. The patient I always think about when we talk about this is a little girl we had who was 18 months old, status post-liver transplant, had breakdown at the anastomosis, so she was leaking a combination of gastric fluid, biliary fluid, small bowel fluid, and pancreatic fluid. By the time they got her through admissions and to the floor, and they called us and we got over there, her skin was already a disaster, and the wound was right at the costal margin. So that made it even harder to get a pouch to stay on right here. It was on the right costal margin. So we sedated her, we pouched her, stayed on 2 hours. Resedated her, repouched her, 2.5. Like, we can't keep doing this to this little girl. So we took the pouch off, we crusted all the damaged skin, we put a very thick layer of zinc oxide, we took the superabsorbent diaper, we put it on and we secured it with the stretch net, and we had the staff change it out every 2 hours. Within 24 to 48 hours, her skin was healed, then we could keep a pouch on. But when she went home, her mom's like, I can't do that pouch thing, but I could do that zinc oxide and that diaper. Can I go back to that? And of course you could. So you always want to have alternatives and options so that you can meet the patient's needs even if they are not a candidate for a pouch. Okay, so just to recap, we start out by trying to get a fistula to close spontaneously. If they seem to have the potential for spontaneous closure, there's no evidence of pseudostoma formation, there's no evidence of distal obstruction, there's no evidence of abscess formation. Spontaneous closure involves reducing oral enteral intake to about 20% of their total nutrient intake for the day and give it to them as a high protein drink or formula that they either sip or that you drip throughout the day. Consider sandostatin to further reduce output, a 48 to 72 hour trial of sandostatin to further reduce output. Use TPN to meet nutritional needs, and use negative pressure wound therapy to try to pull the size of the defect together, further reducing the volume of output and the amount of granulation tissue required to seal the defect. If you're able to significantly reduce output with that combination of reduced oral enteral intake, possible use of sandostatin, negative pressure wound therapy, then hold it in that position, continuous suction for about 3 weeks to give it the very best chance to granulate in, and then start backing off your suction. If you are unable to effectively reduce output, then rethink your use of negative pressure wound therapy. If a patient fails conservative management, either you have done this for 6 to 8 weeks with no improvement, or they develop a pseudostoma, then we know surgical management will be required. In the interim, the focus is on containing the drainage, protecting the skin, meeting nutritional needs. You can liberalize the diet, but you do want to counsel them, don't eat everything just because you want it. So, yes, you can eat for pleasure, but be reasonable. Then your options are, can I pouch them? If that works, great. If pouching doesn't work, what about closed suction? What about the trough procedure? Okay? And if nothing works, go to zinc oxide in a diaper. Okay? And we'll go over some of these things again when you're on site. Thanks a lot.